Welcome back to End Time TV's On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses. With me this hour, Dr. Doron Feinsilber. We are talking this hour about reflex sympathetic dystrophy, complex regional pain syndrome. And before we get into the conversation again, I do want to remind our viewers that you can join this conversation by using your email, ask@endtimetv. Send an email to ask@endtimetv with any questions, comments, concerns you may have. Because we're in a live show, if you're viewing between the hours of noon and 1 o'clock on a Saturday, in this instance, on the Edge, you can join the conversation by typing ask@endtimetv.com. So just before the break, we were talking about the sympathetic nervous system, and I want to remind everyone that this process is tied into the limbic system. And perhaps you can talk a little bit about the limbic system so we can appreciate the background here.
Well, it's a system in the brain that controls our pain perception and also things like our pleasure, things like that, the whole reward and give system, our sexual drive, things like that. So actually going into the particular neuroanatomy does take a little bit more time, but that does tie into this syndrome as well, because remember, you have the sympathetic nervous system, and that's tied into that whole region. There are pain centers in the brain that are going to cause that type of perception. One thing that we talked about, or at least we'll talk about later, is the NMDA receptors, which deal with pain perception and how we control that. And in fact, those receptors are targets for drug therapy that we go to later on.
Okay.
And that's
so because we're tied into the limbic system, we know that pain can be a stress response, like a migraine event. Stress exacerbates the problem, and a lot of these patients end up having a psychological overlay.
Absolutely.
Because they're overwhelmed with the sensation, this pain sensation.
Well, what you're referring to is something called a somatoform disorder, where you may have a psychological trauma that can happen to somebody, but they really will feel actual physical pain symptoms, and that's scary for people because they nothing really happened to them. They just get up one day and all of a sudden they realize, oh my gosh, I can't move my right hand. I have pain in my shoulder. I don't know where it's coming from, and they go and get corticosteroid injections. Doesn't do anything, and it gets very frustrating. So along with reflex sympathetic dystrophy, these other disorders have to be understood as well, because again, all this stuff does go through the brain. One example I can give, people that have irritable bowel syndrome, which is very common nowadays, or at least has been spoken about in more public forums, especially in the medical community, what they notice is that during early development, if a patient tends to have a traumatic childhood, or something happens where there's abuse involved, particularly sexual abuse, what ends up happening is that the actual response from defecation, actually, instead of being routed through the anterior cingulate gyrus of the brain, will actually go through the frontal lobe where you have more pain receptors. So instead of going through those mu or opioid receptors, which cause a feeling of relief, which is associated with defecation, you actually get pain from that. And so, but it is a real issue. It's not made up, which gets really very frustrating for a lot of patients because they say, I don't know what happened, why is this hurting, why am I having all these issues? And it tends to have a psychological base tied to that. So that's something that really is a very sensitive issue with patients, and that's where really the clinician plays a pivotal role, and also really being a counselor to these people and someone you can confide to, and being a good listener. I think that's extremely important in very sensitive matters like this. So that's one thing. The other thing is, I think in terms of diagnosing reflex sympathetic dystrophy, only now I think it's getting to be a little bit more spoken about in the general medical community. Now, when I did a little bit of imaging work this year, we actually did something called a 3-phase bone scan.
Yes, you mentioned that before.
Which is a radionuclide angiography, meaning that you basically are injecting a substance in the body that breaks down, has a radioactive byproduct, and we can actually use images that we see from people to see how blood pooling works. And if blood pooling at certain sites, and we know that there probably is an autonomic response involved with it, and that's how we can possibly pinpoint sympathetic dystrophy from that. So those are new techniques that are being used now for diagnosis. But what's interesting to find out now, there are 3 key stages to RSD that we have to know. And I think you mentioned a lot of them, where you have the kind of like a local pain and tenderness, and then all of a sudden it gets a little bit cold and clammy, which is more the secondary type of symptom. The third is called a deuterian contracture. That's really when you have it for a very long time, where even the muscles themselves are closing down and contracting down and creating little flexures in the musculature.
And in fact, you can get what both tissue and bone wasting.
Yes, you can. Because if you think about it, alpha constriction it causes a closure, and blood supply actually gets cut off to that part of the body. And remember, muscle is a very vascular organ, and it requires perfusion. And if you're constantly having decreased perfusion to it, that's what's going to happen. You will have atrophy and wasting, and that's how you get the contractures. So that's important to understand when you evaluate a patient, to understand where they're coming from and how long they've had these symptoms. If they had, you always ask if they had any surgeries, any major injections. You know, one example of something that I do in the hospital a lot of times is place a central line or a triple lumen catheter, which means if you can't get a peripheral IV stick, you have to go either through the inferior jugular or go through the subclavian or go through the femoral and place a long gauge needle in there, which is actually a minor surgical procedure. A lot of times after they take a scalpel, have to create a small opening, have to take a dilator, place it under the skin. That can also cause a lot of firing of the sympathetic nervous system and cause that as well. And patients who are chronically ill, those particularly go to the intensive care unit and things like that, who do require that type of intervention, tend to develop that. So.
When I was speaking with Dr. Kirkpatrick, he mentioned to me, I had asked him, well, what's the course for most of these patients? What's typical?
Yeah.
Is this something that goes away after a while? Or he said, well, the population that's most successfully leaves this pain syndrome behind are children, young children, when the syndrome is caught early. If they can treat early, then typically this syndrome is left behind in childhood. Mm-hmm. In older children, into adulthood, if this has been going on for some time, it's very, very hard to manage, and becomes a chronic condition and potentially lifelong. Along with that, associated with that, as with many other pain disorders, there's this depression overlay when someone is dealing with this kind of chronic pain. And I wanted to talk to you. He had mentioned that there are some long-term treatments, of course, mobilization, trying to get the affected limb, if it's a limb, mobilized. Dystonia is frequent in these cases.
Right.
So, and then flexion contraction, where they're working against it. Sympathetic block, and I had a short video. We weren't able to watch that this hour, but maybe you can talk about the sympathetic block. Mm-hmm. Using a heated pool with the patients. And then there's a psychosocial treatment. And I asked about some of the kinds of treatment that might be associated with psychosocial. We're going to talk more about these treatments. We're going to a commercial break. Stay with us. You're watching In Time TV's On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses. With me today, Dr. Doron Feinsilber.